Hi everyone, this is Margaret Manning with 60 and Me. This is the place where women over 60 come to be inspired. My guest today is Clare Henry. Clare is the CEO of the National Council for Palliative Care in the UK. And she has been working in palliative care, hospice care for all of her career, started as a nurse and then worked as a director of the National Health System's end-of-life care system and strategy in developing that business, and now is the CEO of this organization called the NCPC in the UK. Welcome, Clare.
Thank you.
It's great to have you here.
I'm really pleased to be talking to sort of women over 60, which is really exciting because I know there's lots of different challenges that women over 60 face.
Well, and that's very true. 60 and Me is about 100,000 women now over 60, and a lot are dealing with end-of-life situations with their aging parents. And also, when you get to be 60-ish, you start thinking, wow, there's less ahead than there is behind. So this question of how to manage the dying process, how to treat patients who are at the end of their life. It's great work that you do. So tell us a bit about, first of all, before we talk about palliative versus hospice care, tell us a bit about the National Council for Palliative Care, what it is and what you do, what your goals are.
The National Council for Palliative Care was set up 25 years ago. Okay. And what we're about is actually improving end-of-life care for all, wherever people find themselves, all ages, and looking at how we can work with governments and also get the public talking about death, dying and bereavement. Right. So it really is sort of saying it's part of everyday life, how we can make those decisions and then get on with living.
It is so wonderful. These kinds of groups are forming all over the world. And I must say that this group that you're working with is in the UK. So we're talking about England, Scotland, and Wales, Northern Ireland. But we talked about this before, Clare, that these issues really relate to women and men all over the world. So remember that, though, as we're talking, that these programs Clare will talk about are related to the UK. But, okay, so look, a lot of people are familiar with the words palliative and hospice, but not too sure what they really mean. So help us understand. What's the difference?
Okay, I think a lot of terminology is used around palliative and hospice care. We have other words like end-of-life care, supportive care. What we actually mean, all the words really, if I can sort of put them together in a nutshell, is that what they actually mean is about how we support, we manage symptom control, we really keep people comfortable. So it is actually managing that whole person. So palliative care is the broad definition, which basically means to palliate, to alleviate symptoms, whether that's physical, psychological or social as well. But I think hospice care has very much come up probably from the word hospice, which is sort of started off as really like a building, but it's grown because hospice care now is delivered not just in the building that maybe was developed across the UK, it's actually sort of outreach into the community. So that's where the word hospice care comes from. But palliative covers the whole remit. So I think we do get muddled up with language. That's why over in the UK, we've been talking very much about palliative and end-of-life care, because end-of-life care, sort of people realise that means the last days of life. Right. I think we get very hung up about terminology, and it's really saying what we're about is supporting people when they have a life-limiting condition or that they're starting to show it when they're getting older, that we're actually managing those symptoms, supporting the family, and then looking at, how we encourage people to live until they die, however long that is. It's that positive living till you die.
So when people think about hospices, they often think about, like you say, the building that people take you to spend the last days, weeks of your life. And it has a sort of a more of a traumatic feeling about it, that when you go into hospice, that's it. You can then start preparing, for end of life. But it sounds like what you're saying, though, is that it's more of palliative care or care of the symptoms you talked about happens in a hospice, but that could be in your home or in another place. Am I getting that correct? Yeah.
Absolutely. And I think it's very much hospices now are not somewhere, I mean, it sounds ironic, but not somewhere just go to sort of die in the last days. People can be admitted, actually sort out particular problems and then be discharged.
Right.
So it's very, very different to how it probably was set up maybe 40, 50 years ago.
Yes.
So it really has sort of, it's looking at the changing demographics because again, like a lot, sort of lot of women is dealing with older parents, and also maybe, sometimes I think, especially when you're sort of in your 60s, we have sometimes people are losing their children as well, which
Yes.
is really traumatic. So you're sort of a bit sandwiched. But I mean, hospices do provide all sorts of care. A lot of it was set up predominantly for cancer care.
Yes.
Now they're actually expanding their reach to people with other conditions and also supporting people when they have lost their loved ones, because we do know that people do need that bereavement support. Hospice care is starting to deliver more of that. You don't have to have had your person, the person who's died, cared for or within the hospice.
Right.
And I think it's looking at all those different things. And the other key element for hospice or palliative and hospice care is really supporting the generalists, so the district nurses, the other clinicians in hospitals, within care homes, because that everybody's delivering palliative and end-of-life care. So it's looking at how we can do that.
Well, I was going to ask you that because when you think about how people often develop, if they have Alzheimer's or dementia, for example, and they end up being in a home where they're being looked after for their own safety or because they just are difficult for families to look after, that isn't hospice care. But as they get closer to the end of their life, they could then have a person on staff that would guide them through the next stages. Is that correct?
Yeah, I mean, what you very much, I mean, with palliative care teams, they will go in and support the care home staff. They'll also go in and see the person who's living in the care home.
Right.
And we know we need to, we've got some very good examples in this country, but we also need to make sure that we're driving up that quality, because we know staff, particularly in care homes, there's quite a high turnover.
Yeah.
So the palliative care team really spends a lot of time supporting both the staff but also the relatives coming in, because when you're coming in to visit, say, your mum or your dad in a care home, you want to be able to sort of think, what else can I do? How can I support? Who can I talk to? Because there's so many issues that come up, especially as you highlighted with dementia. Who can make those decisions on behalf of parents? Have we got the legal power to that?
Yes.
Who's working in the best interest? All of those decisions about how we really think about having those conversations and supporting people, which is very difficult as a relative.
It's really hard.
That.
No, I was going to say, in fact, we were talking before we started the conversation on about the fact that many years ago, 30 years ago, I had the great honor of working with Elizabeth Kubler-Ross, who was a doctor who really was trying to change the conversation about death and dying 35 years ago. And she would always say that one of the biggest challenges was that a dying patient has been sick for some time or has an understanding of what they're going through. They're dying. They're experiencing it. But the family are the people that have the most difficult time expressing their emotions and being ready, letting the dying patient talk. Do you still find that that's a problem or the case?
I think some people feel more comfortable talking about it. And I think this is why, some of the work that we've been doing over in the UK around what we call dying matters is to encourage people to have those conversations earlier. So when people aren't able to sort of say what's important, such as people with dementia, the family know what is important to them and have those discussions. It can be difficult to get started, but once you start to get, you start to say, it's probably easier to say what you don't want rather than what you do want, and start to think, okay, what's important to me, or what don't I want to happen to me? So I think it's interesting. I do a lot of travelling on trains, so I have a lot of conversations on trains, and it's really interesting that some people will tell you, I've had my discussion with my mum, or actually I do need to do that. Goodness me, I haven't thought about, I don't know what's important to my mum, where she wants to be cared for, what she wants to do, what we need to do after she's died. Right. So it's really important. So I do think people have difficulties, because I think especially the media has quite a role to play here, because people don't always see, they think like watching over here, like Casualty, people sort of suddenly have a cardiac arrest and they're all right and they walk out the hospital, and people expect that people will recover. And it's having more of those conversations about, we know death is inevitable, but it's helping us to do things positively so we can get the most out of life.
Well, this has been great. You've really, I think, given me a great understanding of what palliative care is, the things that you do, as you said, socially, physically, emotionally, to help a person at end of life. And then hospice is a broader category now of caring once that care is in place, how you then guide the person and the families through. I meant to mention, Claire, and I congratulate you. Actually, you have been awarded the MBE, which is a very significant honor in the UK, member of the British Empire, by the Queen in 2012.
2013.
And this really, I think, highlights, well, first of all, how you're valued personally, but also how important this topic is.
Absolutely. And it was a great honour for me to receive that. And it's
wonderful.
Lovely recognition for all my colleagues who work in palliative and end-of-life care.
It's a tough job, but we'll talk more about this. So we're going to do a series of interviews. So let's stop here for now. And your website, by the way, is ncpc.org.
Yes, or a lot of the other information is Dying Matters.
Right, and we're going to talk about Dying Matters because that's a group of a lot of different organizations together. So let's talk about that later. And thank you so much for being here, and I really appreciate your time. Thank you so much.